Good morning. I'm going to be doing a presentation for my Tech Com class. I'm a VTC student currently in my RN year. My Tech Com instructor is Jeff Higgins. And this was a proposal that started from a memo all the way to the final request. And it was to implement a change in the organization that I work in. And that organization is the University of Vermont Medical Center, formerly known as Fletcher Allen. I came to the University of Vermont Medical Center in 2011 after the flood of the Vermont State Hospital, where I was a psychiatric technician. My role currently at UVMC is LNA, and I provide care in a safe and therapeutic environment for our patients there. A lot of patients that come there are involuntary, meaning they were of them harm of themselves or others in the community, and some come voluntarily for a range of things: depression, med adjustments, and so on. It was clear when we came from the Vermont State Hospital with our patients, the acuity of those patients were higher than what Fletcher Allen was used to dealing with. They would send those patients to us. So the number of restraints and seclusions did increase after the closure of the Vermont State Hospital. So my change that I would like to see in my organization is a reduction in the use of seclusion and restraints with use of sensory rooms. There are a number of ramifications that can occur when you put a patient in seclusion. You take away the patient's control. When a patient is at risk of harm to themselves or others, the last alternative is restraint and seclusion. We need to know how to work with each individual patient and allow them a choice in their treatment. Without implementing more outlets for patients to make a choice, we are only offering them a few ways to de-escalate, which is not effective in the process. In the article titled Least Restrictive Methods, Alternative to 4-Point Restraint and Seclusion, Morales and Dufresne state, when staff become more knowledgeable about the use of alternatives, they are more comfortable offering patient choices and did not wait until restraint and seclusion were necessary. Planning educational in-service programs for staff to address this content and share approaches to specific situations can be effective. End quote. The bottom line is patients need to be in control of their treatment and need to be offered choices. The next ramification is that restraints and seclusions can be traumatic. It is our job to understand the history of that patient. A lot of patients come to us that have these psychiatric disorders and they have a trauma history. It's the responsibility of those providing the care to know what that history is so we don't further hurt their psyche. On the website, Judge David L. Bazelon, Center for Mental Health Law, it stated, people subject to seclusion and restraint experience it as frightening, humiliating, and dehumanizing, end quote. We need to take these people's trauma history into account and have a plan in place that eliminates the use of restraint and seclusion. It's hard to reach out to someone that's there. They're away from friends, they're away from family. It's a scary environment. It's new. So every interaction we have with the patient is a chance to gain their trust. When we betray their trust, they are not able to get better. And people that are restrained and secluded withdraw from the healthcare team, which makes getting through to them almost impossible. In an article titled Use and Avoidance of Seclusion and Restraint, Dr. Knox and Dr. Holloman stated, both physical interventions and drugs for the purpose of restraint have short and long-term detrimental implications for the patient and the physician-patient relationship. It's true, and we've seen it time and time again in our facility, that when someone becomes restrained or secluded, they become isolated. They don't interact with their peers, they don't come out of the room, and this further worsens their mental state. Not only is it harmful to patients to use seclusion, but it's harmful for the staff as well. When patients are a threat to themselves or others, we seclude and restrain them when no other method is available. Staff in inpatient psychiatry is trained in MOAB. which stands for Management of Aggressive Behaviors. We also have undergone PROACT training, which is Professional Assault Crisis Training. We are trained to deal with aggressive patients, but it will never occur in the same manner that it does in the classroom when we're putting hands on our coworkers. You can consider everything that we've learned in those trainings to go out the window when there is a crisis. In the article titled Use and Avoidance of Seclusion and Restraint, Dr. Knox and Dr. Holloman stated, some healthcare providers may view forced medication, seclusion, and restraint as the safest, most effective intervention for the agitated patient, but are relatively unaware that these interventions are associated with an increased incident of injury to both patient and staff. These injuries are both physical and psychological. In addition, the use of drugs for the purpose of restraints results in side effects that can be problematic. End quote. So, I've mentioned sensory room. So how can we help reduce the total number of restraints and seclusions that occur in the inpatient unit? It's really simple, by implementing a sensory room. So let me explain a little bit about what a sensory room is. According to the Occupational Therapy Innovations, a sensory room is described as the following. Therapeutic spaces specifically designed and utilized to promote self-organization and positive change. There are multiple types of sensory rooms and purposes for use that have been created and implemented in different practice areas to date. When used appropriately, sensory rooms can help to create a safe space, facilitate the therapeutic alliance, provide opportunities for engagement, in prevention and crisis de-escalation strategies, as well as a host of other therapeutic exchanges, or teach skills, offer a variety of therapeutic activities. It can also promote self-care, self-nurturance, and reliance and recovery. So I propose that we implement the use of the sensory room at University of Vermont Medical Center, and the number of seclusions and restraint instances can be reduced by simply implementing the use of a sensory room. This will increase patient and staff safety while giving the patient a choice in treatment. We are proposing turning an existing space on the inpatient unit into a sensory room, which would require minimal construction. This would require purchasing of sensory equipment and training of existing staff. We anticipate a decrease in the number of incidences of restraint and seclusions that occur in the inpatient setting by offering the patient a choice to use the sensory room when they are not at baseline. This is the space we propose on using. It's an old staff area that was once changed into a computer charting area for nurses, and nurses really can't utilize the space because they need to be available where the patients can see them. So this room is not used. So right here would be the entrance, and where you walk in, there's a bunch of empty space. This can be utilized for groups, and patients can socialize there. And there's 1, 2, 3, 4 separate rooms that we can utilize each of the senses in. They're separated by a panel door, so we'd be able to look in on the individuals using that space. These are some of the equipment that would need to be purchased for the sensory room, and it's a little hard to see on there, but we'd have CDs, CD players. The CDs would be of meditation or relaxation, just nice, simple music. There's some bubble lamps for seeing, guitars for tactile, not feeling it, but hearing the music. Just a bunch of activities that they can do. But these all enhance the senses. So, I wanted to incorporate hearing, sight, smell, taste, and touch. So for hearing, we could use the white noise machine, a guitar, an iPod, a CD player, headphones, have fountains in the background, and musical instruments. For sight, we could use a bubble lamp, lava lamp, black light, multicolored light projector. We could set up an aquarium, have plants, photos and artwork, even artwork that the patients make, we could display in there. And for accent, do a sponge painted wall, have murals and posters. For smell, we can use scented oils, diffusers, fresh eucalyptus, lemon balm, lavender, chamomile, dried herbs. We could have scented soap in the bathroom facility, and scented markers for arts and crafts, and aromatherapy supplies. We have different taste buds: bitter, sweet, sour, and umami. So for bitter, we could incorporate baking with rhubarb or just having patients try rhubarb. For sweets, we can offer hard candy. Salty, we could do snacks such as popcorn, peanuts, potato chips, pretzels. Sour, we could do some, cut up some lemons just to have people experience the sour. And umami, those are foods like carrots, sweet potato, and green tea. We could offer all of that in there. For touch, we would have stress balls, slinkies, exercise bands, weighted blankets, ankle and wrist weights, different textured pillows and blankets. They could do sewing projects, knitting, crocheting, beading, finger painting. There'd be a massage device in there, a light bright, Etch-a-Sketch, clay, putty, and Play-Doh. So they could use all that. So who will it take to make this happen? Well, we would utilize our existing staff, which would be the activities therapist, the mental health techs and LNAs, and the nursing staff. To implement this project, we would need a project director, which is me. So I will provide a one-day in-service training for all existing staff. I'll order all products and supplies and ensure the quality and safety of all the items purchased to make sure that they're safe for use for the patients. I'll track sales and deliveries and provide employees with info regarding use of sensory room and its impact on reducing restraints and seclusions. I'll create the hours of operation and scheduling for the sensory room. The existing staff will attend a one-day in-service. They'll have an overview of all the items used in the sensory room with their purpose, and upon completion of in-service, be able to verbalize and do a return demonstration to show their understanding of the products and the use of the sensory room. They'll provide supervision of activities and support to the patient that utilize the sensory room. They'll clean items after patient use, which also includes daily cleaning of sensory room. They'll report broken items for replacement, and a point person will write activity notes on each patient that utilizes the activity room. So the qualifications for this position are currently licensed activity therapists, and they may run and implement groups in the sensory room. Current MHTs with completion of in-service may assist and supervise all group activities. RNs may implement and run health education groups with the prior approval from activities therapists. The RN may have the assistance of MHTs in those groups. All future employees must attend a one-day in-service and have at least 3 years healthcare experience or 1 year psychiatric healthcare related experience. Activities therapists will have a master's level degree, and a bachelor's level nursing degree is preferred. So how long will it take to implement all this? On December 1st, I expect to have the approval, which we already received. December 1st through the 31st, I'll oversee the development of the sensory room. December 7th, I'll submit all the purchase orders for the sensory equipment. December 1st through the 14th, I will train the employees and have a training session and prepare for the new system. January 1st through the 7th, we will paint, furnish, and decorate sensory room. And January 7th through the 10th, that will be an additional training and run through of the sensory room operation. And last but not least is our evaluation period. This will run from January 11th through February 11th, and we'll be curious to see if it does reduce the rate of seclusions and restraints. We'll collect feedback from staff and patients about how they believe the sensory room is working. So you may think something like this is very expensive, but the total cost, including construction, staff training, and equipment, is $14,045.77 to the penny. This does not seem like a big price tag, but compared to the cost of injuries to both staff and patients, and the trauma, and the alliance with healthcare providers, it's not a big cost at all. So during the evaluation phase, as I touched on before, we'll keep track of patient participation in the activities. We'll do documentation on restraints and seclusions. We'll do a debriefing after each restraint and seclusion and see if there is a way that this could have been avoided by using the sensory room. And we're hoping that the use of the sensory room will decrease restraints and seclusions by 50% in the inpatient setting. One goal that we'll strive for by January of 2016 is a reduction of restraints and seclusions by up to 70%. So in conclusion, in order to reduce the need for restraint and seclusions on our unit, we need to implement more choices that are available to the patients to help them make better choices in their care and treatment. When we do not offer more choices for the patient, they are limited in how they can take control of their own behaviors. It is our goal as health providers to ensure patient safety and decrease the incidences of restraints and seclusions that happen on the inpatient setting. That concludes my presentation for TechCom. Have a good day.